Let me kick off. Welcome everyone to Tumor Talk. Welcome back. As everyone knows, this is the weekly webinar that we hold, collaborative effort between the Journal of Neuro-Oncology, Lenox Neurosurgery, and we try to focus on recently published research in brain and spinal cord oncology. And so we're actually very fortunate today to have some neighbors with us from NYU. We have Dr. Sylvia Kurz and Elisa Liu, a medical student who published recently on the paper we're going to talk about today, discussing really the racial and socioeconomic disparities and how they differentially affect overall and cause-specific survival in glioblastoma. We're also pleased to invite along our brain turns, where we have an ongoing virtual webinar seminar series that's been happening at Lenox Hill. And so those students are watching either on Zoom or on Instagram Live, where this is kind of simultaneously broadcast. So I'm going to let you guys introduce yourselves. Everyone remembers Gautam Mehta, my co-partner in this. Jason Sheehan won't be here today, and I'm not sure if John Bookbar will make it or not, but we'll stay tuned. But why don't you go ahead and kick it off, guys? Thanks for coming.
Okay, thank you. All right. Yeah, thank you so much for the invitation. My name is Sylvia Kurz. I'm a neuro-oncologist currently working out of NYU. Yeah, I had the opportunity to work with a really talented medical student, two really talented medical students, really. One is Elisa Liu, who will speak to us today about this recent paper, and then Sharon Yu, if she's on the call. Shout out to her as well. Yeah, so I think, you know, we in New York City, we've had a lot of talk about race and how, racial disparities that really affect society and everyday life. So I think, that might have raised interest in the study that we're going to talk about today, in which we have tried to kind of focus on a few questions, mainly how racial disparities and socioeconomic disparities might affect care and outcome in patients with glioblastoma, one of the most aggressive brain tumors that there are. So with that, I think, so Elisa is going to speak a little bit about the paper and give us some background information and what we found in the study. After that, we'll open up for discussion.
Great, thank you. So once again, thank you to Dr. D'Amico and everyone for supporting these webinars and for giving us the opportunity to talk about our work on racial and socioeconomic disparities in glioblastoma. And just as some quick background, glioblastoma, or GBM, is the most common malignant primary brain tumor, and despite aggressive multimodal therapy, has a poor prognosis with 5-year survival rates of only 5%. And importantly, the median age of diagnosis for GBM is 65, which is a population that already has a high prevalence of comorbid medical conditions, which may also influence the disease course. And so there is increasing evidence that differences in socioeconomic and racial backgrounds may affect access to care and treatment, and may thereby influence patient outcomes. So for example, when looking at the time between surgery and radiation in GBM, these authors found that early initiation of postoperative radiotherapy was associated with improved survival. However, they also found that radiotherapy delays were associated with lower income counties, Medicaid, and Black patients. So for these patients, simply being diagnosed in a lower income county were associated with greater delays in radiation and thus lower survival. And when looking at the role of race in predicting survival, studies have also found inconsistent results in GBM. And so even after controlling for the treatments received, studies have found mixed results as to whether, for example, African-American patients survive longer than white patients. And so some studies have reported poorer outcomes that's at least in part attributable to inferior access to high quality medical care, whereas other reports have found improved overall survival when only examining patients of a high performance status. And so beyond the studies just mentioned, access to care may be influenced in numerous ways. Patients from underprivileged backgrounds have been described to have lower frequencies of gross total resection and chemotherapy, delayed presentation to a hospital after symptom onset, and even more frequent perioperative complications. And therefore, we don't really understand how and to what extent racial and socioeconomic disparities affect survival in GBM patients. And despite the poor prognosis of GBM itself, differences in the incidence and management of comorbid conditions, which are closely tied to patient demographics, may also contribute to mortality and represent an important confounding factor in investigations of overall survival. And therefore, the aim of our study was really to investigate how racial and socioeconomic backgrounds affect all-cause mortality or overall survival. Furthermore, as not all patients with a diagnosis of cancer will ultimately pass due to their cancer, we also sought to identify the differential effects of these risk factors on GBM-specific and non-specific mortality. And so for our study, we pulled case-level data from SEER for patients diagnosed with GBM. And for those who don't know, SEER stands for the Surveillance, Epidemiology, and Results Program that collates information on cancer statistics. It provides incidence and outcomes data by patient demographics and is a publicly available cancer registry that is supported by the National Cancer Institute. And so for our study, we looked at adult patients diagnosed during the temozolomide era or post-2005, leading to a study cohort of 29,000 patients. And in unadjusted analyses of all-cause mortality, we found that race and median household income were significant predictors of overall survival. And so on the left panel, we see that overall survival increased with median household income, with one-year survival rates increasing from 35 to 49% from the lowest to highest income bracket. And furthermore, among racial and ethnic groups in the right panel, we also found that Asian Pacific Islander patients had the highest survival at 53%, whereas non-Hispanic white patients had the lowest at 42%. And to adjust for possible confounders in age, tumor, and treatment characteristics, we looked at a multivariable Cox model on all-cause mortality. And so as expected, we found that younger age, smaller tumor sizes, and the receipt of various treatments were associated with improved outcomes. But we also found that race and socioeconomic status were independent predictors of mortality. And so specifically, we found that increasing median household incomes led to a stepwise decrease in your mortality hazard. Furthermore, compared to non-Hispanic white patients, we also found that Hispanic white and Asian Pacific Islander patients had improved outcomes as well. And while all-cause mortality or overall survival serves as the most commonly used objective endpoint for reporting patient outcomes, it's difficult to interpret whether these higher hazard ratios are confounded by disease intrinsic versus extrinsic factors. And so beyond looking at overall survival, we were interested in evaluating the role of various risk factors on cause-specific mortality. And to that end, we looked at death certificate information to separate causes of death due to GBM and non-GBM reasons. And given the nature of different kinds of death as competing events, we used the fine gray subdistribution model to evaluate the effects of various risk factors. And so unlike your typical Kaplan-Meier analyses in which you only have one event of interest and all other outcomes are censored, the fine gray model allows us to examine the incidence of different competing events. So in our case, this allows us to look at the rate of death due to GBM and non-GBM causes separately, while taking into account the fact that the occurrence of one event directly precludes the other. And so specifically, we're decoupling all-cause mortality to separately model the cumulative incidence of death due to GBM and non-GBM causes. And of all the patients who died, the vast majority of causes of death were attributed to GBM itself, as expected, but a non-negligible portion were attributed to non-GBM causes. And leading causes of non-GBM mortality included other malignant cancers, cardiovascular, and cerebrovascular disease. And so given that we were able to separate the different causes of death, we first looked at the cumulative incidence of mortality attributed to glioblastoma itself. And here we found that the cumulative incidence of GBM-associated mortality was again associated with median household income and race. And so for example, at 1-year follow-up, the cumulative incidence of mortality attributed to GBM was 58% in the lowest income bracket and only 48% in the highest bracket. And furthermore, when you stratify this mortality by race, we again see the same patterns as overall survival, where non-Hispanic white patients have the highest mortality rate and Asian Pacific Islanders have the lowest. But perhaps what's more interesting is that when you examine the incidence of mortality attributed to causes other than GBM, we saw very clear differences in patient demographic. So in the left panel, we found incremental increases in the cumulative incidence of non-GBM associated death with each decreasing income bracket. So from the highest to lowest income group, the incidence of death due to non-GBM causes increased from 3% to nearly 7%. And these differences persist in the long-term setting as well. We also found that the incidence of non-GBM associated mortality was similar between all racial groups except for Black patients, whom had a significantly higher incidence rate as seen in the elevated orange curve in the right panel. And after controlling for differences in tumor and treatment characteristics, we found different risk factors for GBM and non-GBM mortality. And here we are showing the subdistribution hazard ratio for GBM mortality in pink and non-GBM mortality in green. And so interestingly, when we look at median household income, it played no effect on GBM-associated mortality. But in contrast, we found that lower median household income was a significant predictor of higher non-GBM mortality, and that there is an incremental decrease in harm with each higher income bracket. And in the highest versus lowest groups, the risk of dying due to a non-GBM cause is cut by more than half. Furthermore, we found that Black race was a significant predictor of increased non-GBM mortality as well, despite being associated with improved outcomes in GBM-specific mortality. And so this is an example of where overall survival was not actually different between non-Hispanic Black and white patients, even though there are clear differences in their disease course on a population level. And so this discrepancy between lower GBM mortality but higher non-GBM mortality in Black patients represents an important confounder in race-based outcomes in GBM. And this highlights the necessity of decoupling disease intrinsic versus extrinsic factors that may ultimately influence outcomes, but in very different ways. And so in conclusion, we found that racial and socioeconomic factors do influence glioblastoma-specific and non-glioblastoma-associated mortality, and that patient race has an impact on GBM mortality independent of tumor and treatment-related factors. And despite the aggressive nature of glioblastoma, we found that a non-negligible portion of deaths in these patients can be attributed to non-GBM causes. And here we are seeing a significant but variable dependency on county socioeconomic status and patient demographics, which leads to a very different incidence of deaths due to other cancers, cardio, and cerebrovascular events. And the fact that we're able to see these differences on a population scale highlights a clear need for improved access to medical care and specialized providers that not only manage GBM-related aspects of care, but also pay attention to GBM-unrelated comorbid conditions. And lastly, we wanted to highlight that overall survival is still arguably the most objective and relevant clinical endpoint for patients diagnosed with GBM. But by decoupling the different causes of death, we can better understand how these various backgrounds influence outcomes in GBM patients, and to ultimately develop more targeted strategies to overcome disparities in care for GBM-related and comorbid conditions. And as for our study limitations, we wanted to highlight that even though we took a very dichotomous approach towards dividing the causes of death by whether they were attributed to glioblastoma or not, there is likely a significant interaction between these two outcomes. And so especially in the setting of GBM treatment where disease and treatment complications are frequent, it is difficult to completely isolate each cause of death. And furthermore, while SEER provides population level information, it does lack some detailed clinical parameters such as performance status, tumor biomarkers, and the presence of comorbid medical conditions. And lastly, our analyses cannot identify any causal relationships between disparities and outcomes, and we can really only speculate the reasons for the observations we're seeing in this study. And with that, I'd like to thank you all for your attention and open this up for any questions or comments on this topic.
Great job, Elisa. Thanks so much. And thank you, Dr. Kurz, for coming along again. We'll let the chat features open. If people have questions, they're welcome to start putting them in. I guess, my first question is, were you surprised by this initially? The results are obviously a little bit different than what you would expect when you initially read even the title of the paper. And so I imagine you went into this with a hypothesis. Do these results differ from your initial hypothesis? Were you surprised by the findings? Dr. Kurz, you're muted, I think.
Okay, got it. Okay, great. Thank you. Yeah, so Lisa, I'll let you comment as well. I do think the one thing that I want to highlight is if you go in the background literature on this topic, you already find a lot of papers that tell a different story. So there are a bunch of papers out there that kind of claim that, for instance, Black Americans, African Americans will have like a worse outcome, have limited access to medical care for glioblastoma than others. And yet there are other papers that found that actually the outcome for Blacks versus non-Hispanic white patients are actually very similar. So there is like the literature is already a little bit diverse. So I guess going into the study, we were trying to prove, or like we went into the study with the hypothesis that that maybe it was not the case that non-Hispanic whites would have like superior outcome than people would actually believe. There is, sorry, I want to actually say also there is like also some literature on the so-called Hispanic paradox, which means that that patients of Hispanic backgrounds actually seem to have a better outcome, not only in GBM, but in other cancers really, like GU cancers and prostate cancer for that matter. So we actually, one of the hypotheses going into the study was to prove whether a Hispanic paradox was maybe true in GBM patients as well. And then we of course wanted to look at whether there's a difference in outcome for Blacks versus white patients. Yeah, Lisa, do you have any other comments on this?
Yeah, I was definitely surprised by how clear the various risk factors kind of separated into what aspects of mortality they affected. And so we actually took a fairly crude approach because it's difficult to fully separate causes of death based on death certificate information. And so we've actually also done some subset analyses, so looking only at cardiovascular events, for example. And here we can dive into that. We didn't dive into that in this presentation, but the role of these factors in cardiovascular events, for example, is even greater than what we're arguing than non-GBM mortality itself. So it's just insane to me that even as something as aggressive as GBM, that we can see such clear disparities and various other events that are not just due to the cancer itself.
Yeah, I mean, I find this very, very interesting because to me, when I read your paper, what I see is that we actually are doing a good job with GBM, access institutions. So Lenox Hill, what we do is we actually, we have a few satellite hospitals that feed to our cancer center. And so, regardless of race or socioeconomic status, if you come into our system, you have access to clinical trials, the same clinical trials that people in a high-income county have access to. But what it appears like is that actually it's these other issues that are going on that are compromising their health. And so what you really need is almost a bigger multidisciplinary approach where you need to incorporate primary care into these patients. And I think that this points a lot of fingers at primary care as being a major issue. I mean, based on your numbers, the Black population actually does better with glioblastoma than what you would imagine the non-Hispanic white population, right? And so to me, this says that we're doing a decent job, at least at academic centers that are putting forth their SEER data, versus the primary care world, which is maybe where we're failing these patients.
Right. No, and I think that is an important finding of this study, that you have to kind of not only look at these GBM patients as a whole and kind of lump everything that happens to them under the GBM diagnosis, but actually to look what is actually causing an issue here. And I think like a practical example for primary care related issues in patients with GBM is, for instance, like, diabetes control, blood sugar control, because a lot of these patients will receive steroids, right? And that drives up blood sugar readings. But how does that actually possibly negatively affect their care and ultimately the outcome? And I think often we have the approach, the steroids are more important to improve neurological symptoms and improve quality of life in these patients. And I mean, often a logic is applied where we say, well, the the high blood sugar numbers won't be as critical because the patient is unlikely to live long enough to have like the sequelae and the consequences from their uncontrolled diabetes. And based on the results that we found in this study, I think that is a call to actually pay attention to these details, and maybe these details do actually matter, and we have to make sure that blood sugar levels are appropriately controlled, and blood pressure is controlled, and cardiac conditions and so forth.
Yeah, absolutely. Got him. Did you want to say something?
Yeah, I think you know, this is really interesting because we're so often taught that disease-specific survival is a very imperfect outcome for clinical trials and clinical studies. When we're studying a specific therapeutic, and that might still be the case, but I think what you've kind of demonstrated in this is how important disease-specific survival and understanding these non-disease comorbidities are to kind of caring for the whole person. So even if it's not important for clinical trials, or we shouldn't be using it for clinical trials, we should be thinking about this as practitioners and for treating these patients. I think the other thing that that I found really interesting about this, how clearly you guys presented the SEER data, and I think often from reading a lot of these registry papers, I often am left more confused than I was before I started reading it, and I think you guys just did an excellent job of presenting the data and going through the data and being very balanced in terms of how you interpreted it. The discussion in your paper in particular, I think, is a very good example for a lot of the medical students, residents, trainees in our audience for how a discussion should be written. And I think it's really kind of an easy and good read.
Yeah, I agree with Gautam. Excellent job. You know, just to play devil's advocate a little bit, I guess, and because we brought up the SEER database itself, you know, one thing that I found very interesting was some of these non-GBM, you know, mortalities were associated with other cancers. And I find that very interesting because I think, you know, anecdotally anyway, it's rare that you see GBM in association with another cancer at the same time. And I would say it's even more rare that that other cancer is the primary, you know, reason for death. But your data suggests otherwise. Do you think that is just a limitation of the database itself and the coding, or do you think that's a real phenomenon?
So I can speak on that a little bit.
Sure.
So we completely acknowledge that there were a lot of unknown cases in terms of what the actual cause of death was, and we did our best to eliminate. I can actually.
Yeah, I saw in the supplemental data, right?
Right. So eliminate anyone who had an unknown behavior neoplasm as their primary cause of death, or just anyone who just didn't have cause of death certificate available. But we completely acknowledge that it is a limitation of SEER to have so many people who are inputting data, and there's not necessarily a consistent standard for how these are reported.
Yeah, and it's obviously it's you know, kind of diminished in fact by the fact that you know 29,000 people in the study. So hopefully that gets, you know, squashed a little bit. Let's see if there's any questions coming in from the chat room here.
In the meantime, do you guys know if there's any implicit bias in how SEER data is collected? I know it's limited to certain states, but is there
I was thinking the same thing, yeah.
Related to SEER that might lead to bias in terms of how patients are accrued or registered?
So my understanding of SEER data is that there's quite a few unknowns, and that's the unknown coding, and that's actually one of the biggest sources of errors. But they've actually cross-referenced SEER with, for example, like the Medicaid database, and have found positive predictive values, for example, of treatment received, of their race recode to be in the high 80%. So again, it's by no means perfect, but to my knowledge, there isn't like a systematic bias in terms of the way the data is recorded.
Great. Yeah, I think you guys did a fantastic job. The takeaway for me is really this idea that we have to communicate better with the primary care doctors. We have to create a team-based approach to these patients. We really have to optimize them both from a glioblastoma standpoint, but also from a non-GBM standpoint. And that's how we're going to increase longevity. You know, the devastating fact is, you know, overall the survival here is still limited, and we still need, you know, more studies and more accrual and clinical trials to get answers. And I think that you guys did a great job. It's a well-written, you know, fantastic paper, and I appreciate you guys coming on board.
Of course.
We we like to limit these to about 30 minutes or so, just to keep people interested. We have one question actually, just quickly, is questioning, is the data only from the US? And then is age factored into the racial disparities as well as socioeconomic status?
Yes.
Yes.
Go ahead, Elisa.
So yes, SEER is based on US and US territories. And two, all of our analyses that are multivariable do take age into account. And so for something like non-GBM mortality, we do see that older age is correlated with greater mortality rates as well.
Did you guys do any cross analyses with things like looking at race and income or median household income, or were there not enough numbers for that?
We did not look at that specifically, but I suspect that there are very clear correlations between minority populations and lower income counties, for example.
Yeah, that's what I would expect. Well, fantastic job, guys. Thank you so much for coming along. This will be on YouTube probably by the end of the week. So for anyone who missed it, please feel free to share with everyone. I don't know if you guys have your social on the slide, but we'll tag it in ours, Gautam and myself, and we'll make sure people know about you guys. And thank you very much. I can't express enough thanks.
Okay, great. Thank you so much for inviting us and having us.
Of course. And everyone else, we'll see you next week.
Thank you.
Thank you.
Take care.